So the nature of the Kawasaki aneurysm does appear fairly discrete, in the sense that certainly the San Diego group have highlighted a far greater prevalence of calcium within the wall of the aneurysm. Often as an adult cardiologist, when we're faced with an aneurysm, the greatest concern in fact is the ongoing expansion of that aneurysm and the risk of rupture. It's very difficult for us to have a true feel for the kind of natural history of Kawasaki aneurysm, but it does appear that these tend to be fairly calcified and relatively stable in their manner, in the sense of continuing expansion. The greater concern and the aspect that causes me the greatest anxiety is the thrombotic potential of the aneurysm, and then this awareness that the nature of the arterial change at either end of the aneurysm, driven by the shear stresses and the flow dynamics within the aneurysm, results in this myofibroblastic kind of stenosis, this thickening, which can then lead to ischemic manifestations for the patient. I think, as an interventional cardiologist, actually the patients presenting acutely with thrombotic occlusion of the aneurysm, that is often the ugliest intervention that we have to face. And I think that might be where sometimes the distraction is trying to offer the best acute care for the patient, and then actually losing sight of the need particularly for the ongoing prevention and protection against further thrombotic occlusion. And so we often will discharge patients just on dual antiplatelet therapy, where actually we know there is an absolute need to be anticoagulating these patients long term to prevent further occlusive thrombus.